I'm going to move to consider the issues raised by the section of your report headed the role of patients and patient representative organisations in healthcare policy. And I'm going to start in the first instance by directing these questions to Professor Vincent and then again for others to join in. Lawrence, could we have the report, the expert report, back on screen, please? And could we go to, I think, what should be page 45? No, 45 electronic, 39 internal. And it's the table at the top of the page, if we could just look at this. So you've adapted this from a framework in a published framework that you've referred to. But it looks, in broad terms, at three different aspects or areas in which patients might be involved. Direct care, so their own diagnosis and treatment, and then we see there the different ways in which patients may be involved in that respect. Now, I'm not proposing to ask you further about that particular issue because it's an issue that the inquiry's already had a lot of evidence about the extent to which patients should be given information and enabled to give informed consent and so on. I want to focus on the other two areas, improvement and innovation, and then governance and patient safety. Now, in terms of improvement and innovation, is it right to understand that in broad terms that's referring to involving patients or patient representatives in the formulation of new policies or the development of new services?
Yes, I mean, it might be at the level of government that Michael and Claire have been talking about, or it might be within the NHS. So if you're trying to redesign a service, or even if, you know, at the level of redesigning your outpatients department or something like that, or your diabetes service, it makes a lot of sense to speak to the people who are actually using it in order to understand, you know, what works for them, what doesn't work, and so on. But there's lots of, I mean, the reason we had a table is to indicate that just talking about patient engagement or patient involvement in itself doesn't mean much. And you've got to think, well, okay, well, what are we actually talking about in practice? So if you're talking about the design of services, you know, it can all be going to just chatting to people, to having somebody sort of fully involved in the group.
And hence we see in the middle row on this table different levels of engagement. So it can be focus groups and surveys at one end of the continuum, patient interviews about priorities, through to actual patient participation in the committees or organisations or structures that are developing the policy or service.
Yeah, the you know, surveys and things, that's just an illustration. I mean,
Yes.
It's really a sort of, you know, are you just consulting people, or are you actually giving them any real power, I suppose, or at least serious influence in the process? And there are pros and cons for doing that, and it's not a straightforward issue, I think.
In relation to England, there are statutory duties now under the National Health Service Act of patient involvement and consultation imposed on both NHS England and on the integrated care boards. But how good in practice are NHS bodies at involving patients in the more fundamental way of involving them to help really fully shape the policy or the service?
I think the honest answer is it's very hard to know, and it's, to give you a blanket answer, I suppose we've concentrated in the report, because in the few pages we had on the barriers and the difficulties and so on, but I think the reality is that certainly NHS organisations, NHS trusts vary hugely in how they go about this, you know, how the interpretation they place on these sort of obligations, I mean, and agencies too, I think, and the success in which they engage people. And there are certainly trusts, for instance, who will bring patients into the board meetings, who will start their board meetings sometimes with a patient story or something, and that's can be very, very influential on, as we were saying earlier, on reminding people what the organisation is there for. And, you know, they may not take part in the board, but there's a case for that. But I think there's probably also the other thing to say is there's probably a lot of confusion about how to do this and what is really important. And I think often a naive assumption that because somebody's got an illness, they're going to have something useful to say. And to some extent, if you're looking at cancer or diabetes, just talking to those people who are actually experiencing it is enough. But for these higher level roles, it's not clear that simply having a patient on a committee or someone who happens to be there, is a useful thing to do. And how best to actually really centre the work around the patient is not as simple as just sort of saying, well, we'll have someone in the room. I mean, it can be if you've got a really good person.
But potentially that can also be tokenistic.
It could be.
Yeah.
It could be, and also I think potentially sometimes it can be a waste of time for those people involved. Now, I'm not trying to diminish the importance of this. I'm just saying it's not as simple in terms of actually how to do it effectively. And you can imagine the problems multiplied by sort of bringing someone, into a big high-level meeting at the Department of Health. It's a big ask. It's not that it shouldn't be done, but...
Professor Pollock.
Perhaps I can shed light on how it used to be done. So I worked in 7 different district health authorities within public health departments. Now, health authorities used to have responsibility for all the services in their area, for the organisation, the funding and the delivery. So they were the eyes and ears as well of the system. And there used to be 3 departments responsible for service planning and including users and patients. There was the public health department, which had information within it, embedded within it, so we could see where services were, where the gaps were, etc., and who wasn't getting the care. We could monitor that. As well as that, there was a planning department with surveying as well. And we would all sit down together, including with our services, and we would have patient user groups with special expertise in, say, mental health or diabetes or sexually transmitted diseases, and they would be consulted and included in helping to us as part of what we called a needs assessment. Public health had a needs assessment, which had an epidemiological approach, identifying service gaps, but also involving users. Now, that actually, it worked fairly well, but the other eyes and ears, contrary to what Michael said, were very important with the community health councils, especially in some areas. Now, they were heavily underfunded, but they would also bring to our attention services where there were gaps or where they were or they would campaign against closures. Sometimes we were up against them as well. But there was a system in place. Now, the 2012 Act actually dismantled that system completely. We no longer have area health authorities, boards, we haven't had for some time. But public health, with all its needs assessment, which was responsible for identifying and working with user groups, was completely carved out of the NHS. It's no longer there. And information now on patient needs is now part of the contracting and commissioning process. So it's no longer involved in service planning. So that whole system approach has gone. And I think that's really important to understand. And I think a really good illustration of this is mental health services. Today in England, if you need a crisis mental health bed, you cannot go locally. You have to get on a website. You look at all these big private companies, and they will say which hospitals there might be a bed. And as you know, people have to travel 500 or 600 miles to get an acute mental health bed. That could never have happened before when you had a responsibility for planning and organising your mental health services locally. But of course, part of the privatisation and marketisation has been the closure of these services and the lack of responsiveness and the lack of good mechanisms to feed in the patient groups and their needs. So I'll stop. But we also had joint services planning committees as well with local authorities. So we work very closely with the services in our areas and the local authorities. That also happened at the regional level. Region was there to help coordinate activities and to help with the service planning so there wasn't too much duplication. And that also happened. The regional groups also had patient user groups as well.
I mentioned the statutory duties of public involvement and consultation, but those are very broad terms. Yeah. Insofar as the NHS in England is concerned. Do you know, Professor Vincent, or do any other members of the panel know whether there are any particular structures or obligations built into the systems in Scotland, Wales or Northern Ireland in terms of ensuring patient involvement in the development of policies and services?
I don't. Is Claire?
Well, that's a factual gap, sir, that we'll no doubt seek to plug. Can I then, if we go back to the table, I wanted to pick up the third area there, governance and patient safety. And again, what's identified there is that there may be a continuum of engagement, again, from the example at the one end of the continuum in the table is surveying patients about their experiences, and then we have involving patients as advisors or members of an advisory council, through to patients playing an active role in trust safety investigations or national policy committees. And so I just wanted to spend a little time on the role of patients in patient safety investigations, and then look at some of the developments, the new developments, Patient Safety Commissioner and so on that we see at the moment. Excuse me. Has there been a shift over the last couple of decades in terms of the idea of patient involvement in investigations about what went wrong in relation to their care or the care of a member of their family?
Yes, certainly, I think. I suppose you need a bit of context for this, that although people, I mean, going back, decades, have always sort of done some reflection on when things went wrong and individual investigations and so on. I mean, actually having a formal approach to it is perhaps only the last 20, 25 years in the NHS. I don't mean that there was nothing done before that, but it wasn't sort of institutionalised, if you like, until the mid-90s. So just getting that up and running, and even now there are lots of problems in, the standard of investigations done, and it's become somewhat of a bureaucracy. I mean, I worked on developing methods, so, I've sort of tracked this for a long time. And I suppose, again, it's going to vary a lot between trusts. I think it probably varies between, say, mental health and acute, about the way these things are done. And I suppose there's been a slow recognition, firstly, perhaps, that it was very important to provide explanations to people. I mean, this goes back 20, 25 years to studies on finding that people who are suing, for instance, I mean, I did studies myself on this, it wasn't often for the money, as I'm sure many people here would know. It's to find out what on earth happened. And I think you'd say that there was a considerable skepticism early on about whether that's really what people wanted. Now I'd say that's completely accepted, and you would never hear anybody questioning the fact that the explanation to people is important. So that's, if you like, a degree of engagement in the investigation, the sharing of what's happening, the asking people for their story. Now, the question of whether, to what extent it's meaningful to involve people in the actual investigatory process is coming more centre stage now. And I mean, recently I've been involved in a group working on the national, various aspects of this. And a huge part of this is looking after people who are potentially traumatized and trying to put that centre stage. Now, I know that's not, you may think that's a little peripheral to what you're asking, but actually it's very, very critical. And I think the national groups and the guidance, I'd say we're probably at the stage of exploring how fully to involve patients and families in investigations, bearing in mind that the wishes of the family and people involved is going to be hugely variable. And some people want to be completely involved, others may not. And I don't think this is really understood. And to my mind, the issue of how traumatized people are, because I've talked in the past to lots of people in these situations, is a very big issue. And it may not be a good idea at an early stage. It may or may not be a good idea to involve. And how you do it, you can involve somebody very fully by just having a very quiet and intimate conversation with one person. That can be a deep involvement, if you like. It doesn't necessarily mean bringing people into committees and so on. But it does require a commitment to honesty and openness and creating trust and all these things that we'll all understand. How to do this and how to be sensitive about it, and bearing in mind that, you know, many trusts are doing multiple investigations, and it's hard to know. I just thought, I suppose my own feeling is, if you're going to involve a family in a serious investigation, you either do it properly and you give it time and you do it fully, or it's probably better not. And to do it badly, I think, is potentially, I suspect, quite damaging. So it's a long answer, but it's a big issue.
Not at all, and I just wanted to pick up on the issue of trauma, because it's a topic you've explored, I think, in an article entitled Patient Safety, What About the Patient, which is at RLIT 0001760. And this is talking, I think, both about the involvement of patients directly in their care, but also about the management of and the impact that the after an adverse incident, how that is managed and the impact that can have on a patient, and how that can increase a patient's trauma.
Yes.
And if we go, I think, to page 3, just wanted to pick up on a couple of the passages here. Under the heading on the left-hand column, after the event, the impact of serious incidents on patients and their families.
Yeah.
The second and third paragraphs say this: the impact of a medical injury differs from most other accidents in two important respects. Firstly, patients have been harmed unintentionally by people in whom they place considerable trust, so their reaction may be especially powerful and hard to cope with. Secondly, and even more important, they're often cared for by the same professions and perhaps the same people as those involved in the original injury. As they may have been very frightened by what has happened to them and have a range of conflicting feelings about those involved, this can be very difficult even when staff are sympathetic and supportive. In addition, patients and relatives may suffer in two distinct ways from injuries due to treatment. Firstly, from the injury itself, and secondly, from the way in which the incident is handled afterwards. Many people harmed by their treatment suffer further trauma through the incident being insensitively and inadequately handled. Conversely, when staff come forward, acknowledge the damage and take the necessary action, the overall impact can be greatly reduced. Injured patients need an explanation and apology to know that changes have been made to prevent future incidents, and often also need practical and financial help. And then that's developed further in the article. I'm not going to read further into the article, but how well recognised now within the National Health Service are the points that you make here, in particular about the potential for greater trauma for patients?
Well, I think in answering this, I'm mindful that, and even discussing it, there's probably people in this room for whom this is very pertinent, so I hope I'm not going to distress anybody. Not that I'm going to say anything that you probably don't know already. I'd say there's recognition. I mean, on a human level, there's recognition. What I think is much less clear is whether people know how to do it and how to respond. And I think still many people would find it very difficult to open up that conversation about how distressed someone is. Not through sinister motives, but because if you start talking to somebody about, whatever the distress is, you can't open the door unless you've got some way of helping them afterwards. And I think we've got to the point where the explanation, the openness, and as emphasised by Robert Francis, now become the duty of candour. That's recognised. But to me, that's just the kind of beginning. Now, for serious things. Now, I mean, there are many things that go wrong in healthcare which, are distressing at the time but have no particular long-term consequences, and, basically people will be all right. And for those sort of things, there's a whole continuum of problems. An explanation, a simple apology and saying, well, really sorry about that, it's all fine. But of course, there's this huge gradation. And I don't think, But at the moment in the NHS, we have, in any sort of organised way, quite thought enough about how to handle the more serious end of things. Now, of course, there are many people working with the NHS with experience of working with depression, anxiety, trauma. I'm talking about the psychological side. I think the physical side of people's injuries is probably handled more routinely within services. And of course, many clinicians know that they may be treating someone who's had a very bad experience in the past, which then they become aware of. And it can have a colossal influence on the behaviour of the people involved. So the knock-on effect is considerable. I mean, if I'm talking too much, tell me. I could,
No, not at all.
could go on about this, but
Just then talking a little more about investigations or for patients trying to raise concerns, trying to say that something has gone wrong and be listened to. Your report's identified a number of barriers, one of which reflects what you've described, I think, as profound asymmetries of power and the still very hierarchical nature of the NHS. We talked about the hierarchical nature of government, central government earlier, but in relation to healthcare professions and organisations, your report observes those are still very hierarchical. And so it can be difficult for a patient to feel they're even able to speak up and say, I think something went wrong, or I think I have been harmed, when faced with that asymmetry of power and that hierarchy. Again, what work is being done within the NHS to try and address that and enable people to be able to say something has gone wrong and be listened to?
Again, it's quite hard for me to give an answer to this in a sort of single way, and other people may be able to say more about this. I suppose there's two issues. One is raising the concern in the first place. And I think the second one we might think a bit more about is the sort of integration of this information and how it's used. So, for instance, there are multiple ways of raising concerns in the NHS, but it's quite hard to know where you want to go. There's the PALS service, as Alison mentioned, which I think is very good for certain sorts of things, and they will often resolve a lot of things at local level. It works very variably. You can make a complaint. I think you can report directly into the National Instant Reporting System. But it's quite a muddle about what you should do, I think, and where you should go. And if I wanted to raise a safety concern, I would be, I know things fairly well, quite hard put to know where would be the best place. Or should I go to the consultant in the case, which is probably what I would try and do if that was the issue. And I think the asymmetries, this is not sort of some sinister plot by the NHS, but I think it's more that the usual thing, that if you're articulate and middle class, you'll find a way and you can push. But many of the problems happen to people who are the most vulnerable. And it's just hard, it's hard work and you don't quite know how to go about it. It's all the sort of usual things. So I suppose what we say in the report is that this is an issue for individual patients, but if you want to create what you might call safety intelligence in your organisation, then you need to not just wait for people to come to you. You'll have to go out and talk to them. And, this could be done by sampling patients or bringing them into groups or doing the sort of things that Alison was talking about. There's lots of ways of doing this. But to sort of generate that kind of information. The other issue, I think, in a lot of NHS organisations, that they may have quite a lot of information, but pulling it together into a meaningful whole is another thing entirely. And I remember, for instance, I worked recently in an NHS trust where they had a very good patient experience department of half a dozen people who did a lot of things. I don't think they ever spoke to the risk management department, who were just sort of across in another building, or contributed much to the improvement programme. So the sort of joining up of this sort of information is a big issue. And indeed the resourcing of safety and quality information, which we could also talk about.
Can I then just ask you a little about some of the current initiatives or proposals for either enhancing patient safety or enhancing investigations. The first I wanted to ask about is the idea of the Patient Safety Commissioner. Now, that's an idea that emerged out of a recommendation from the Cumberledge report, the first do no harm, accepted by the Department of Health and Social Care, and in England there is now legislation in place, and a Patient Safety Commissioner has very recently been appointed. The remit of that Patient Safety Commissioner, as I understand it, is in relation to medicines and medical devices, which is obviously the specific issue that the Cumberledge Review was looking at. But before I ask anything about what's happening elsewhere within the United Kingdom, do you have any observations or thoughts on the role of the Patient Safety Commissioner and whether the role of the Patient Safety Commissioner should or could be wider?
Well, I think the honest answer is no, I don't know enough about it. Yes, I know that there's going to be somebody appointed. I don't know what their remit is. And I think Michael or Claire would be best placed to say how they're going to be influential within government. I think it's worth reminding you that we used to have a National Patient Safety Agency from about, I can't remember when it was founded, about 2004 until it was abolished in 2012. And, you know, people have varying views about what the use of that and the value of that. And now we have the Health Service Investigation Branch. But the Patient Safety Agency was a bit wider. And quite apart from the fact that they could do things like provide training, provide a kind of core activities and so on. And of course, importantly, we have a National Patient Safety team now under Aidan Fowler. So there's lots going on. But I think the agency had what you might call a symbolic value as well, which I doubt that any one person can have. It meant, I suppose, that safety was never off the agenda because we had a national agency not only pulling information together, but promoting constantly. And I think now you might do things differently, you might think more broadly about this, but I suppose however good the commissioner is, they're not going to have that kind of influence.
And do you know, or do any of the other panel know what the position is in relation to a patient safety commissioner in Scotland, Wales or Northern Ireland? No, well, again, that is a further factual matter that the inquiry is investigating. You referred to the Healthcare Safety Investigation Branch. Can you just tell us in a sentence what that is, what it does?
Okay, it's recently, I think, attained full sort of independence as an authority, and it's been running about 4 years now, and it emerged from a parliamentary committee recommending there should be such a body. And it's equivalent, I suppose, very broadly speaking, because I was involved in writing about these things before it. And I think the idea is it's like the Air Accidents Investigation Branch. And the important thing about the air accidents people is that they are independent from every aspect, every other part of the industry. So they sit outside, if you like. So this means that they can issue, and this is the same true of the Health Service Investigation Branch, and this is, I think, worth a little explanation. They can investigate and issue recommendations to anybody in the system. So they can issue a recommendation to the Department of Health, to the Secretary of State, to the Care Quality Commission, to a particular organisation. And what they do is not so much investigate single issues, where they'll take an exemplar case, but say there's, there's an anxiety about whether people with mental health problems get effective treatment in accident emergency departments. I'm just making that up as an example. You know, they might look at one particular instance where there were difficulties, but then use that as a sort of springboard, if you like, to look at it on a national level and say, systemic issues is what they should be looking at, big systemic issues that infect services a lot. But the important thing is the full independence is absolutely critical. And also the idea of having a core of expertise. So if I may say that rather than having to kind of start again and learn about everything with an inquiry where you have to assemble a team and it all takes a long time, the idea is that not to replace inquiries entirely, but you have a core of expert people sitting there who can be mobilised really quite quickly, and also can engage with other people in the health service. So they work a lot by bringing people in from the NHS, which of course creates further expertise. Anyway,
I think, as you've alluded to, my understanding in relation to the Healthcare Safety Investigation Branch is, because its focus is on systems and processes, it doesn't seek to attribute blame or liability. And I want to come back to the idea of no blame cultures and what you've also described in the report as a just culture in due course. But just sticking then with some of the other developments, and again, I'm afraid it's potentially going to be Anglo-centric again. The Patient Safety Incident Response Framework is something you've referred to in the report, and my understanding is that that's a framework set up by NHS England and by the Healthcare Safety Investigation Branch. What is that framework, again, in broad terms?
in broad terms, and I should say that it hasn't been out very long, and I'm no expert on this, but it's a guidance for NHS organisations of all kinds about how to investigate safety incidents, the criteria for choosing them. There's actually a lot of guidance now as part of it about involving the care of families and things, and it's not that this guidance didn't exist before, but this is a sort of much more substantial revamp, if you like, of previous guidance, and which we've had an instant reporting system nationally since Sir Liam Donaldson initiated in 2000, I can't remember exactly when it became national. And there's been successive guidance about what to report, how to report. And this, I suppose, this newer guidance is fuller. I guess more emphasis on the analysis and sort of reflection and the involvement. You know, it's got several new elements.
Yes.
But I can't say that I can give you chapter and verse. It's quite extensive.
No, but just for the benefit of others and for you, sir, there is a range of guidance that's been produced over the last few weeks, so very recently, and certainly since I think the panel's report was provided. And there will be available either later today or tomorrow on relativity, so for the benefit of legal representatives behind me, the particular guidance dealing with engaging and involving patients, families and staff, and the reference for that is RLIT 0001810. Again, I think we'll need to try and pick up as the inquiry to try and map what's happening in Scotland, Wales and Northern Ireland in those respects. There's then a very, again, recent suggestion of another form of commissioner advanced by the Professional Standards Authority. And I just want to touch on that. That is set out, if we look at RLIT 0001736, there's a report here produced by the Professional Standards Authority for Health and Social Care, headed Safer Care for All. And for the benefit of those listening, is it right to understand that the Professional Standards Authority is the body which effectively regulates the regulators? So it regulates the activities and oversees the activities of regulators of health and social care? Yes,
but I think, if I'm right, I think it's that they have responsible for the regulators of individuals rather than,
yes.
Doctors, nurses, not of the system regulators like the Care Quality Commission or the MHRA.
Yes.
Yeah.
No, that's absolutely right. And if we go on to page 3, the functions of the Professional Standards Authority are there set out, and the professional regulators that they oversee are set out on the bottom of the page. I just wanted to pick up the recommendation that's made in this report at page 14. This is in the executive summary, where they say this: there have been many improvements in health and care professional regulation over the last 2 decades, leading to greater transparency, better governance and a clear focus on public protection. However, the disheartening recurrence of failings indicates that significant challenges remain in the quality and safety of health and social care across the UK. And then they refer to their report and identify 4 key themes: tackling inequalities, regulating for new risks, facing up to the workforce crisis, accountability, fear and public safety. And they say these are big problems and we do not have all of the answers. And then they set out a number of ways in which they propose to use their own role. But then if we look on the right-hand side of the page, the last two paragraphs, they say this: the issues we have identified in our report lead to one overarching conclusion, that the UK needs a more robust approach to ensuring that health and social care are safer for everyone, overseen by people focused on this aim with the tools to realise it. Our overall recommendation, therefore, is that each UK country should have a health and social care safety commissioner or equivalent function with broad responsibility for identifying, monitoring, reporting and advising on ways of addressing patient and service user risks. And then the report sets that out in more detail. Are there any observations or thoughts, Professor Vincent, that you have on that proposal before I open it out to the panel more widely?
Well, briefly, I'm not going to comment on the specific suggestion because I haven't read the main report, and they may have very good reasons for proposing this, that there should be this person as it sounds. But if I'm thinking about what they're trying to do, identify, monitoring, reporting, advising, that's quite a task. So my question would be, firstly, what resource are they going to have to do that? And secondly, as Alison was saying earlier, to me this is about systems of collecting information. I think we have a lot of information, but very little capacity to aggregate it and track. And if we think about the discussion we had, well, at an early part of this particular report about future risks and so on, the question really is what capacity the system has, either at national level or at local level, to track, monitor, and interrogate safety information. And what's clear is that other safety critical industries invest a lot in this, and we don't. And that a commissioner could be an important person in communicating what is learned to other people, and that could be a very important role. But without the underpinning systems, I can't see how they're going to manage that massive task. Now, that's not a complaint about the suggestion or about the Professional Standards Authority. It's simply to say what is needed underneath that to make it work.
Yes, I'm sorry, I'm just trying to check the date of this report because I don't think it's necessarily as recent as I indicated. It is 2022, but I don't know exactly when it was issued. I can't find the date at the moment.
Could I just add a postscript? I haven't read this report before, but when it talks about a disheartening recurrence of failings, there could be two reasons for that. One is that there isn't someone like a Health and Social Care Safety Commissioner. In other words, the regulation system is not as robust as it might be. But the other reason could be that the culture of the organisation is not a learning culture. And if that is the case, then however robust the conclusions of a commissioner is concerned, it's still probably not going to make a big impact. And although the aviation industry is often cited and can be a bit of a cliche almost, if you look at that industry, somehow they've changed the culture so that people are seeking to learn, because you don't see a depressing recurrence of crashes and near misses in the way that maybe you did. We haven't done that in social work. Social work, the aim is to blame someone, to find out what happened. There isn't, I think, a learning culture within that profession yet. I just want to make the point that it's not just about the robustness of the commissioner, it's about the culture of the receiving organisation. I think you probably agree.
Oh yes, absolutely.
I'm going to pick up on some ideas about reflective learning and ability to learn once we've considered issues relating to candor and transparency. But before I do that, are there any other contributions from the panel on the issues that we've just been discussing? Professor Armstrong.
Yeah. Could I just add that I think one of the first safety mechanisms in the NHS was over 50 years ago. They set up a confidential inquiry into maternal mortality so that every woman who died in childbirth, pregnant and in childbirth, was individually investigated. Now, this was possible because this was a rare event at the time, a bit like the air accidents, which are rare events. So you could look at every woman who died, and there were several dozen in the UK who died every year during childbirth, and there was a confidential inquiry which again discovered where things went wrong and reported to all the obstetricians in the country. And what we saw following that was a gradual diminution of the number of deaths. So it's extremely rare nowadays for a woman to die in childbirth. So that was very successful, but it was a very rare event. And I think there is a difference having systems for rare events and having things which are much more common and much more diffuse, which I think Charles has told us about.
Yes, I mean, there is a very good example, as David says. I mean, there are multiple people working in their different ways in the Royal Colleges or the nurses or whoever on different issues. And we could talk extensively about it. But perhaps the most important point, I think, as David has triggered, is although we're focusing on what the government is doing and so on, the patient safety activity, if you might say, is huge in other factors. You know, I used to work in surgery, for instance, for 10 years, and the way surgery sort of took on a lot of the sort of thinking about safety was quite remarkable. And now there's, you know, it's quite commonplace now to have lots of discussions and articles on safety in surgery and so on. I mean, surgeons are always personally very concerned about it, and every individual, but the sort of idea of doing it systematically and thinking about it as a system is widespread now. So there's a lot of good things happen beyond what we're talking about.
Can I then move to consider, I think probably fairly shortly for the next topic, the issue of communication of risk. Now, this issue is addressed in your report, internal pages 43 onwards. We don't currently need it on screen, Lawrence. In relation to the communication of risk about specific treatments by clinicians to patients, I'm not going to be asking you much about that. This inquiry has heard a substantial amount of evidence from a medical ethics panel and also has reviewed extensively a range of guidance over the decades about issues relating to, for example, informed consent. And just as a reminder, again, for the benefit of those listening, there is a written presentation which pulls together all the different guidance and publications from the GMC and others at INQY 40249, and there was an oral presentation on the 28th of May 2021, so that's available on the inquiry's website. So I'm going to concentrate predominantly on the communication of risk to the public or to larger patient groups. But just before I do that, there were a couple of points I wanted to pick up about communication of risk to patients. One of the observations that you've made in the report is that there is research which shows that people can have considerable difficulty in understanding risk. Can you assist us in understanding the work that's been undertaken to try and address that or improve people's understanding of risk?
Okay, so this is not particularly my specialist area, if you like, so bear with me, but this is the most colossal subject. This is the first thing to say. And, you know, the psychology of it is quite complicated, the different ways in which people interpret information. And we give some examples. You know, if you hear something is 90% successful, you react very differently than if you hear it's got 10% failure. There's all sorts of things like this. There are some very nice examples of people trying out different methods. So in surgery, for instance, you know, it'd be common for surgeons to talk between themselves about percentages of different types of complications and failures. And for some kind of people having surgery, that's meaningful, and they're, you know, probably most of the people on this panel, well, that would be fine to sit there and think about percentages and so on. Other people find that much more difficult, and, you know, for instance, I teach about a very nice study I saw where instead of thinking about the numbers so much, the surgeon would sit down with the person and say, okay, best case scenario, this is what happens. Worst case scenario, this is. Now that's something that people can imagine, because it's not just a numerical thing. And you've got to somehow incorporate the preferences and values of the person concerned. And this is going to vary hugely if you're 80 years old and you have no dependents, and your decision may be quite different from if you're 30 and you have 3 young children with the same scenario. So it's not all about risk, and perhaps the risk element of it may even not be the most important to the people concerned. Now, a clinician or a surgeon here could talk to you at length about the difficulties of trying to match that with the person in front of you. So it's tempting to think that the sort of numbers and the risk are the key issue, but I think it's a lot broader than that in trying to, if I'm on the sort of track of what you're asking about.
Yes, Professor Pollock.
Well, you've got David Spiegelhalter.
We have.
So he's the expert on communication of risk. But I just wanted to bring in one other aspect, which is about disease surveillance, which we touched on yesterday, and how important it is people understand, and clinicians understand, incidence, prevalence, and mortality. But for that, you need very good denominators. Now, one of the effects of dismantling the health service and area-based health bodies is we've lost the denominators. And this shift to providers means we've got what's called floating or unstable denominators that are constantly changing. So it's going to be increasingly difficult, especially if we're tackling inequalities at small areas, to do the necessary surveillance and monitoring that we need, because we are losing and we've lost the local, which is so important. The local is important for gathering information, but also for analysing information to look at area-based differences, say, in access or outcomes or haemophilia rates or whatever, really, really important. So I can't stress enough how important these area-based bodies were for surveillance and for stable denominators as well.
Professor Armstrong.
The idea of risk probabilities came into medicine during the 80s and 90s. It percolated through from epidemiology into clinical medicine. Both patients and clinicians were bemused by these new risk these percentages and so on, and to make sense of them. The way clinicians mainly responded, and it's still a problem for them, there's still literature now about how clinicians don't understand risk probabilities. One solution was to have clinical guidelines or protocols where an expert committee would summarize all the data with lots of risk probabilities and give guidance on what should happen in certain situations. So the last 20 years in the clinical world, more and more clinical practice is governed by these protocols which try to summarize the risks, though even these protocols can vary because depending on how you interpret the risks. And for patients, as Charles has said, it's very, very complicated. And the more research we do into understanding risk communication for patients, the more complex it gets. So there is no simple answer, and I don't think there ever will be a simple answer for patients. But nowadays, because doctors are a bit bemused by it, they often share this information with the patients, and they can because there are specific numbers they can share with the patients, and that's called shared decision making. So the doctor and the patient can try and make sense of this information together.
And then if we turn, still within this section of your report, to the issue of providing information about risk to the public, if we first of all go to page 45, internal pagination of the report, please, Lawrence. So page 51 electronically, I think. We've got the heading at the bottom of the page, informing the public, and it explains risk communication in public health has been the subject of extensive research. Much has been learnt about how risk can be communicated effectively. And then some examples are given. I'm not going to go through the examples, but generally speaking, what would you say are the hallmarks of an effective public campaign communicating risks?
I don't think it would be wise for, I've never been involved in either researching or delivering one. And I think, but the reason we put this in here is because, let me put it this way, I'll be reluctant to just sort of start summarizing the key things. But there's an extensive amount of research on how to do this. The clarity of the messages, formulating the messages. And if I wanted to find out about it, and I was listening to Michael yesterday about commissioning I wouldn't have to sit there and make it up, and I wouldn't have to sort of invent it as a policy. And there's lots of things about how to frame the messages. I mean, one sort of key thing is if you want to change somebody's behaviour, it's much more likely, for instance, that you try and frame it in a positive way, rather than, as there's been some recent examples, rather than sort of threaten people with fines or something. You're much better off in trying to understand and facilitate their behaviour and support it, and give the general impression that everybody is doing this, rather than, as is sometimes the other way. So it wouldn't be hard to formulate the kind of essential principles, and that's what we were trying to get across here. We knew you didn't want a kind of long disquisition about what they actually were, but...
And then if we could go to page 46, please, Lawrence. You were asked to consider the respective roles and responsibilities in terms of public messaging about risks for the provision of information to patient groups. And I just want to read out what you say in this paragraph and then ask you a couple of questions about it. Picking it up in that paragraph, 4 lines in, responsibility for communicating risk which affects large numbers of patients across the NHS would ultimately rest with ministers in conjunction with the Chief Medical Officer and advisors. And then you make the point, if it's risks emerging within a particular NHS organisation, responsibility would rest with those in charge of that organisation. And I just want to pick up a little more about the roles and responsibilities of the Chief Medical Officer and ministers in this regard. So if we look to the bottom of the page, you've referred here to the Nolan Principles, the requirement that holders of public office should act and take decisions in an open and transparent manner, information not being withheld from the public unless there are clear and lawful reasons for doing so. And then, if we go to the next page, you say in the first paragraph, and obviously we touched on this yesterday, that Nolan Principles long-standing, well-established, therefore they're a reasonable statement of what should have been expected of ministers and civil servants in the 1970s and 1980s on the subject of messaging risk, as well as a guide to the present day. And then it's the next paragraph I want to particularly ask about. You say this, the principle of openness set out in the Nolan Principles clearly implies that ministers have a responsibility to make information about risk publicly available unless it was judged to be speculative or incomplete and not therefore in the public interest. Now, the reference to information being speculative may be, I think, more self-explanatory, but it's the reference to information not being complete that I wanted to pick up. It may rarely be the case, particularly if you're faced with new and emerging risks, that departments, ministers, civil servants, chief medical officers have complete information. They will only have, at an early point at least, partial information, and that may persist for a very long period of time. It might be said it's more misleading to withhold even that partial picture from the public, and that the right course in terms of what the Nolan Principles require, and indeed what public safety may require, is to provide the information that you do have, but qualify it by making it clear that that information is not complete. Any observations on that?
I'll just say something brief, because I think I'd be better to pass to Michael and Claire on this at this level. As you say, the information is for an emerging risk like SARS or COVID or Ebola or any of these sort of things is always going to be incomplete. I suppose my immediate thought is that there's not a lot of point in releasing information about a threat unless there's some action people can take. And unless you have some action, then you're just going to inflame the situation potentially. So I guess you need to have some sort of positive direction for people to take if you're going to start just releasing. To release information saying there's a threat coming over the hill is not in itself, I'd have thought, advisable, unless you have something to follow it with about what precautions, what to do, and so on. So there's quite a lot involved in assessing this, but this is, somewhat of a lay view in this case, so I'm going to see if other people might like to say something about
I think quite an interesting example is CJD, which when it came out, remember the little prions, like viruses that get into the brain and cause a very devastating illness. And there was a concern at one time with mad cow disease, people might remember, that this would somehow get into the population. We'd have an epidemic throughout the UK. And some people were talking about tens of thousands of deaths. Now, these were some experts were estimating tens of thousands of deaths. Other experts were saying, I doubt if it's going to be a major problem. Now, therefore, that information was incomplete for a minister, for a CMO, for anyone. We've got experts who are saying tens of thousands of deaths, some of them saying no deaths. And in the end, it happened much towards fortunately, towards the small end. So it wasn't a risk. Otherwise, everybody would have been asked to stop eating beef and beef burgers. Remember, there's all that. John Gummo was feeding it to his daughter and things. Yeah, I said enough. Thank you.
Okay. Professor Pollock.
Well, I think there's no problem with releasing information, but also emphasising where there's a lot of uncertainty or unknowns. And I think the COVID pandemic is a very good illustration. There was, and there still is, uncertainty about the evidence around masks and even testing. But it's absolutely the case. So there are a lot of unknowns, and what the government should say is this is what we're advising, but these are the unknowns and uncertainties, and this is how we're going to address them with careful studies and trials at the same time. And I think that was one of the really big limitations that led to huge polarization, both politically and within society. And that's where government can play a really important role in just facing up to uncertainties and unknowns and saying this is how we're going to address them and how we're going to design special studies to address them.
Ms Salters, Lord Bishard.
I just want to say a little bit about the issue of incomplete, and you're right, you can never have an absolutely complete data set until the event is over. But I think, for me, incomplete in that sentence is about insufficiently complete for you to be able to draw reasonable conclusions or a range of conclusions. So it's a variation on speculative. You've got not quite enough information to be able to say where on the spectrum something is going to be, and you could therefore be in the, are we talking about 2 cases, are we talking about 100,000 cases, because they're very different. So you would want to get more information, a more complete, not absolutely complete set of information in order to be able to make some kind of meaningful assessment for it to be useful. Otherwise, you're in the territory of we could die if we drink too much water. Yes, but there's a huge amount of drink it, not eat it. There's a huge amount of that you would need to get through before you hit the actual risk. So you need to know enough to make it a useful bit of information to share with people.
Yes, I mean, I appreciate this is at a level of generality, and much will depend upon the specific situation, the degree of information you have, and presumably the seriousness of the risk. So a risk of something mild as opposed to the risk of something potentially fatal. So there'll be a whole range of factors that presumably feed into that.
Yeah, I agree. I was merely going to add, not very helpfully, that all of our knowledge is incomplete. And what we're talking about here is a judgment being made as to when to make public our incomplete knowledge. We should be seeking, and civil servants should be seeking, to expand our knowledge as quickly as they can before any statement is made. I agree with Charles that actually when you make a statement, it's much more powerful if you can say, and this suggests that we should be doing something differently. The only thing that hasn't been mentioned, I'm not sure where it takes us, but it's also perhaps important as to who is making that information available, by which I mean, are they trusted? And I think we've seen some of that during the pandemic, and the way in which in this country some individuals were trusted and therefore put in a position where they were communicating the information. Some weren't trusted. You've seen it even more in the States, I think. So it's just that we haven't talked about that at all, but you can have information, putting it in the public domain, think about who does it.
So I'm going to move to a separate topic. Well, it's related very much to what we've been talking about, but it's a separate part of the report looking at candor and transparency. So perhaps we could do that after lunch.
Yes, well, let's take a break then until 2 o'clock. 2 o'clock.